It's my privilege to invite a senior consultant in rheumatology and rehabilitation and past president of CSRRSL, Dr. Duminda Munidas.
Thank you for your kind invitation, Jayatri, to putting me as chairperson for this session. Hopefully everybody had a good lunch, and hopefully Prof. Sulaiman will not make sure that you'll keep awake this post-lunch session. So he's prepared questions also. So be awake and be prepared to answer them during the lecture. So it's my great pleasure to invite Professor Sulaiman Al Mayouf, consultant in Paediatric Rheumatology at King Faisal Specialist Hospital and Research Center, Medical College Al Faraz Hospital, Saudi Arabia, to talk to us on SLE and monogenic lupus. Over to you, Professor Sulaiman.
Thank you very much. And first of all, thank you for the kind invitation and for the hospitality. And special thank for the organizing committee and namely Jayatri for everything she did. Probably in the coming 1.5 hours or less, I will talk about lupus from different aspects. And as the chairperson said, I have few slides like MCQ or slide-oriented MCQ. If you wish, we can take it. We have many questions. If you like it, we can split it today and tomorrow. So without further delay, I choose this title because I know most of the attendee will be adult rheumatologists. So I thought I will talk about lupus layout for a better understanding. This is the outline. I will just give brief overview of lupus and the impact of age on lupus and childhood lupus across the age categories among the childhood period, and then we'll compare the differences between childhood and adulthood onset. I have nothing to disclose in regard of this presentation. As we know, SLE is the prototypic multi-system autoimmune disorder. Maybe it's the best autoimmune example among other diseases. It has the onset may be acute or insidious chronic, but it's not. There is a common saying: lupus is commonly known as the disease of with 1,000 faces, as it can lead to wide variety of clinical laboratory findings that differ from one person to another, and moreover, probably the manifestations change over time. So in reality, it represents a syndrome rather than a single disease. So to understand the lupus, there are few key factors for a better understanding, including ethnicity, age, gender, etiology, and organ affected. So these are the main key factors, and under each one you will find there are multiple elements, and these, what I meant by these elements, you can see the ethnicity. We have African, Asian, Hispanic, and Caucasian. The age, the adult onset, late, and very late onset among adult patients, and childhood onset we have pre and peri and pubertal age group. I will discuss this in some details. And of course, we have the etiology. Part of my talk today will focus on the monogenic or inherited or Mendelian lupus. And of course, as it is multi-system disease, the organ involvement can be spread from the skin till the CNS and arthritis and so on. So let us take ethnicity as an example. And you can see the ethnicity plays a significant role in the epidemiology, clinical presentation, and outcomes of lupus. And we are familiar with the fact that the incidence is higher in Asian, African, Hispanic compared to Caucasian, though most of the publication came from the Caucasian. So we don't know much about our group or ethnicity. Probably from China there are some data, but from other countries or ethnicity we don't have many data to study. And the African tend to develop lupus at a younger age and have severe disease, while lupus in Asian is associated with higher risk of nephritis. And in general, lupus outcomes appear more severe in African, Hispanic, or Asian comparing to Caucasian. Now, regarding the etiopathogenesis, the exact cause remains uncertain, but we know that lupus is characterized by dysregulated immune responses. And so far, there are more than 100 susceptibility loci for lupus, and these loci may involved in immune regulation, interferon signals, and antigen presentation. So any defect in these loci may lead to immune dysregulation, hyper secretion or production of interferon, and so on. And many factors can modulate or trigger lupus in genetically susceptible individuals. So for the environmental sun exposure, some medications, infection may trigger the disease in susceptible patients, especially with these loci, as I said. For more detail, there are major pathogenic factors play role in lupus, and these can be summarized under two items. Number one, increased rate of apoptosis. And the problem here is the defect clearance of apoptotic cells. So there are many deaths of the cells, but the clearance is lacking. So the immune system exposed to self-double-strand DNA, and this will trigger or induce autoantibodies. And the immune complex formation from the double-strand DNA and anti-double-strand DNA will trigger the secretion or the production of interferon. And there is belief that interferon type 1 is the driving force in lupus pathogenesis by participating in inflammatory reactions and dendritic cells maturation, as well as activation of autoreactive T and B cells. Saying that loss of tolerance to self-antigen potentially associated with defect in genes that regulate the immunological self-tolerance and genetic variation that alter immune regulation. So most of these immune pathogens is probably related to some genetic defect or variance variation in the susceptibility loci. And the end point probably with excessive excretion of interferon, this probably the cause, and maybe you are familiar or aware about the new medication approved for lupus, which is anifrolumab, which is anti-interferon medication. If we talk about the diagnosis, we use the classification criteria. This is not for diagnostic purposes, but people can talk and understand each other, and we have many classification criteria, and one of these are ACR classification criteria, and also we have SLIC criteria, but the most recent one, EULAR ACR criteria. And I will not go in details because already my colleague presented a nice case and she explained the using of this classification criteria to make a diagnosis. So in brief, the general framework for SLE classification criteria, the SLIC, you need to have, for the ACR, you need to have 4 out of 11. The SLIC, the histopathology or histology compatible with lupus, nephritis, and ANA or double strand will be enough to call lupus, and this is called standalone renal SLIC criteria. Or we have to 4 out of 17 at least one immunological, one clinical manifestation. And the new criteria, which is AULR, ACR criteria, ANA positivity is a must, and then we have to collect 10 points out of the items of these criteria. For the clinical manifestation, I cannot talk about everything, but I just show you this figure, and you can appreciate that any organ, any system can be affected with different frequency. And you can see childhood also, probably lupus patient probably present with more constitutional symptoms in terms of fever and renal involvement. And we know that the renal involvement probably is more severe in children as well. I split the manifestation as lupus out on the outside, and you can see the malar rash, which is the famous rash in lupus patient. Oral ulcers can present with nasal ulcers, and they may have also peripheral vascular disease ended with ischemia, and patient may end with discoid rash, alopecia, MSK manifestation in form of synovitis, large or small joint, and Jacob's arthropathy, one of the manifestations, especially in adult patient. If we talk about lupus on the inside, you may see or find serositis, pericarditis, hemolytic anemia, pancytopenia, glomerulonephritis, and for CNS, you may find a patient with infarction or even white matter changes. And of course, the neuropsychiatric manifestation is wide as well. So if we talk about the neurological manifestation, CNS manifestation occurs up to 45%, and the CNS may precede other clinical manifestations. And this is very important, especially if the patient presents with chorea. Of course, we need to think about rheumatic fever as a cause for chorea or movement disorder, but SLE is one of the differential diagnoses. And before the diagnosis of CNS lupus, all the time we need to exclude others, especially infection. So if you see a patient newly diagnosed or the working diagnosis of lupus, you need to think about CNS infection as a cause. And the convulsion, yes, it's a bit scary, but it doesn't mean it has poor prognosis. Some patients, they present with convulsion, but if it's not associated with stroke or change in consciousness level, probably the outcome is good. Now, the cerebrovascular accident is not uncommon, especially if it's associated or accompanied by antiphospholipid antibody syndrome. In regard for lupus nephritis, it's common. Up to 60% of lupus patient children, they have nephritis. However, at the level of histopathology, maybe up to 90%. So it's very common among childhood lupus. And it ranges from mild glomerulonephritis to severe diffuse proliferative glomerulonephritis, and usually presented with proteinuria, hematuria, but we have patients presented with isolated hypertension, and some of them presented with renal impairment or renal failure. So it depends on the severity as well. So we know that lupus nephritis may present or constitute a major cause of morbidity and mortality in childhood lupus, and the significant renal disease most of the time develop during the first 2 years of onset. So if you see a patient, these 2 years probably is more critical. After 2 years, you may relax, and they will not develop, most probably they will not develop nephritis in the future. So talking about the impact of age on lupus, typically lupus mainly affects women during childbearing years. However, it can develop at any age, and approximately up to 20% of lupus patients develop the disease before their 15th birthday. And now there are small percentage, up to 10%, developed after or in elderly people more than 60 years. So age has a significant impact on lupus with respect to clinical and serological expression, disease activity, comorbidities, and mortalities. Go back to the key factors. Probably in this presentation, I will focus more on the age factor, particularly pediatric group, exploring the potential differences across age categories to better understanding childhood lupus. But I have to say there is no consensus on the age cut for early or late onset in adult or children. Now, if we talk about adult, probably I will provide a brief comparison between the different age group of adult lupus. Now, we are talking about adult lupus, not children. Most studies define late onset in adult as occurring at or after age 50. So from 60 or 65, age cutoff gains importance as average life expectancy increases, so people do more studies on this age group. And then, unfortunately, there is limited data available on late onset comparing to younger patients. But from the available data, the female predominance decreases with age, ranging from 7 or 18 to 1 in early onset, talking about adult patients, to maybe 7 or 4 to 1 in late onset, and likely due to differences in estrogen level. The late onset suffer longer delays in diagnosis because people, they don't propose the diagnosis of lupus and they don't entertain it as one of the differential diagnoses. So it takes longer time to make a diagnosis. And also late onset patients are mostly Caucasian, again, because the available data came from the Caucasian population and we don't have enough data from our ethnicity or from our regions. So this studies showed patients with late onset lupus, talking about people more than 50 years of age, exhibited lowest rate of major organ involvement and highest comorbidities, and elderly onset patients showed the lowest score of SLEDAI, which is the disease activity score, and achieved lupus low disease activity score the most. While in the very late lupus patient, female predominance, as I said, less marked with less frequent arthritis and double-stranded DNA and low C3 levels. In the opposite, the Sjogren syndrome and RA are more common in those patients. What about childhood lupus? There are a lot of studies from different countries and from different ethnicity, and the comparison also have been conducted. And the peak age of childhood lupus onset is in teenager, around 12 years, and estimated annual incidence among children probably up to 2 to 3 per 100,000. If you have busy pediatric rheumatology clinic, probably 5% of new diagnosis in pediatric rheumatology clinic will be lupus patient. However, still the incidence of frequency of SLE comparing to GIA is low, 1 to 10. So if you see 10 patients of GIA, probably you will see 1 patient of lupus as a new diagnosis. Now, in children, we prefer to categorize the age stages of children into pre-pubertal, peripubertal, and pubertal. Again, there is no consensus. If you talk to your colleague from endocrinology, they used to this classification, but still the age cutoff is not well established. If we compare the pre-pubertal children data To the pubertal, again, it's limited, so we don't have many studies about pre-pubertal lupus. So the data that suggests that all offer disease severity, particularly cytopenia, cardiac, renal, and pulmonary involvement, is inversely related with the age onset. So as the patient has older, they have probably more manifestation, and the adolescent or pubertal onset patient have a strong female prediction, while early onset has no general gender prediction. So if we summarize the early onset, talking about pre-pubertal, talking about children less than 5 years of age, typically they present with unique clinical laboratory features at disease onset, often display atypical presentation, and some of them they lack autoantibodies and typically require higher dose of corticosteroid and more immunosuppressive medication. There is a recent study from UK. They reviewed 480 patients and they categorized the patient into pre-pubertal, peripubertal, and adolescent. And they found the adolescent patient present with higher number of classification criteria and have higher of clinical and serological features and SLEDAI score, almost like adult lupus, while pre-pubertal patient less frequently presented with hematological low complement and renal involvement. So you don't expect to see the usual or typical manifestation of lupus in young patient. There is another recent study from China. They studied more than 800 patients, and the time at diagnosis with lupus during the pre-pubertal period was significantly longer than that of patient diagnosis during the peripubertal and adolescent, and this because the symptoms of those patients are not typical, so easily missed and may be labeled with other diagnosis. And this is from our clinic and colleagues from Oman. We are seeing many patients with young onset because of high consanguinity, and we are seeing patients probably less than 5 years of age, and we compare those patients with the older patients, and we notice those have early onset and male gender are associated with higher disease activity and also renal disease and end-stage renal disease. So what is the basis of heterogeneity of lupus among these age group? Data shows that clinical lupus features and severity vary by age of onset, suggesting different underlying pathomechanism. We know that SLE is a complex autoimmune condition with a strong genetic component and dysregulation of interferon pathway, which is the innate system dysfunction, considering as a primary and essential pathogenic factor in lupus. So we have genetics and epigenetic and also different pathogenic mechanism probably explain the heterogeneity among patients with different ages. Now, if we compare adult with pediatric, I think already we are aware about the difference, but let me put it in more systematic way. Both ages, they share same classification criteria, adult and children. We use the same ACR or AULAR ACR criteria or SLIC. We apply the same classification criteria, and there are many studies that have compared the lupus in adult and children. However, most of these studies comparing these groups of patients often limited by small samples and came from single institutions or single ethnicity. But if we compare the adult and pediatric, we can see that at least from nephritis point of view, we can see renal proteinuria more in childhood lupus and more glomerulonephritis, and also they have more active sediment comparing to adult comparing to adult lupus. And they have more severe symptoms and required more treatment, including corticosteroid. This one study comparing the adult from Egypt, again talking about single ethnicity from single institution or country, and they found arthritis was more common in adult, while nephritis was predominant in the childhood lupus, and nephritis also tends to be more active in childhood lupus. It's the same findings. But I believe the most evident came from a meta-analysis and systematic review. This is a study reviewed more than 10,000 patients. And again, they found that significant difference between childhood and adulthood, with childhood lupus being more aggressive and show higher frequency of neurological, renal, and hematological involvement at diagnosis comparing with adult lupus. And the pulmonary involvement, rhinoids, malar rash, and photosensitivity were significantly higher in adult SLE. This meta-analysis indicated that remission is infrequent in adult lupus and extremely rare in childhood lupus. Means those patients in childhood lupus have severe disease and require treatment, but rarely to be in remission even after aggressive treatment. So if we talk about the clinical course of lupus, you know that preclinical because of the autoantibodies, and after that the patient will develop inflammatory they will develop some inflammatory or initial organ involvement, and they will have frequent flares and may end with comorbidities and damage, especially if there is infection with it. So how can we approach patients with lupus? I know this is basic, but just to make it more clear, all the time we need to take detailed history and physical examination. And we know that there are no specific manifestation for lupus, but we have to dig in the history and physical examination. And lab investigations are broad, but we need to highlight the autoantibodies ANA profile and complement level, antiphospholipid, and we shouldn't forget urine protein creatinine ratio. And at least in tertiary hospital, we prefer to do like a screen for PFT if the child is able to do it, and we need to do baseline echo and chest X-ray, and if there is any suspicion of nephritis, we need to do a renal biopsy as well. Now, for the management, despite disease heterogeneity, certain goals of treatment in SLE may be applicable. We need to suppress the inflammation, control disease activity to reach remission. If it's not remission, at least lupus low disease activity status. We need to prevent disease flare as much as we can, delay and prevent morbidity and mortality, and avoidance of drug toxicity. So we don't need to kill the patient because of our medication. And to improve ultimately we need to improve the quality of life for those patients. Now there is a special consideration in children because of age. The long disease duration means they are exposed to more medication and probably more side effect from the medication and the disease itself. We are concerned about growth and development, the pubertal status for patient, and also the vaccines, because patient on immunosuppressive all the time, we need to postpone or delay the life-attenuated vaccine. Of course, the adolescent age group is a critical, and all the time we have to consider it, and especially for medication adherence and for the education and involvement of the family in the management. This scheme just to show the relationship between goals of treatment and lupus as a proposed strategy. Number one, we need to control disease activity and prevent flares as much as we can, and to avoid the drug toxicity, and the goal to prevent damage, and of course to improve the quality of life and survival. I will not talk about the medication because this is a bit long and we need to discuss in details, but steroid or corticosteroid remain the first line of treatment. So I cannot imagine treat patient with lupus without using steroid. And the high doses may be needed initially for remission induction, then you will wean it slowly. The corticosteroid-sparing agents are essential for refractory or steroid-dependent cases. And the recommendation now, how would you wean the medication? At least in adult, they prefer to, or not prefer, they recommend to keep the patient on treatment at least 2 to 3 years before in remission, before thinking about weaning the steroid, then or weaning the immunosuppressive medication. After that, then you will consider weaning medication. If the patient has nephritis, they will treat up to 5 years. So this is long-term plan of treatment, and the family and the patient should know about it. And in regard of DMARD or immunosuppressive medication, maybe these days the preferable immunosuppressive is Sulcept or MMF, but still azathioprine can be used. Cytoxan, though people get away from it, but you can consider it for severe cases, especially cerebritis and refractory nephritis. And we have the new medication, tacrolimus and falciparum, one of the new approved medication. In regard of biologic agent, the belimumab, as you know, is approved for children and also for adults. And rituximab, although it's off-label, but we use it a lot, especially for refractory cases. And I already mentioned the infrolumab, recently approved for adult lupus, but not for children, and this especially for patients with bad skin lesions. So the treatment depends on the organ involvement, and we shouldn't forget the hydroxychloroquine has significant role in maintenance therapy, so this should be as a background of your treatment unless there is contraindication or allergy to the medication. And you need to think about low dose of aspirin in case of antiphospholipid antibody syndrome. So the one of important part of the treatment, the supportive treatment, we shouldn't forget it. We need to control blood pressure in those with hypertension, and also we need to provide nutritional support, immunization, and sunscreen, as it's one of the possible trigger for the disease activity. So in conclusion, lupus is a multi-system disease with unpredictable course. Children are likely to have aggressive clinical course than adults. Early onset disease probably influences the long-term outcome of childhood lupus, and infection remains an important cause of death in childhood lupus. So probably this is the first part of my talk, and I need to, excuse me, can I change to go to the next slide? Yeah, monogenic, yeah. So what about monogenic lupus? It's rare, but it's there. So maybe some of us don't see cases, but at least in busy clinic, I'm sure some has many cases. In our clinic, we have a lot of patients with monogenic lupus. So in this brief talk, I will highlight the clinical heterogeneity of lupus, focusing on the inherited group. I discuss the heterogeneity of monogenic lupus, and highlight the unmet management needs in monogenic lupus. So again, already you saw this slide just to emphasize the variety of clinical manifestation of lupus. The etiopathogenesis, it's a matter of interaction between environmental triggering factors, genetic factors, and immune response dysregulation. So if we talk about details about the pathogenesis, in lupus patients, double-strand DNA resulting from impaired clearance of necrotic cells and nets stimulate autoantibodies production by autoreactive B cells aided by autoreactive T cells. So the immune complex will trigger the production of tumor necrosis, interferon type 1 via intercellular DNA sensor in phagocytes and plasmacytoid dendritic cells. And interestingly, the interferon type 1 plays a key role in lupus pathogenesis, driving inflammatory responses, tissue damage, and maturation activation of T and B lymphocyte. So this slide, probably part of it already, I mentioned it in the previous talk, the loss of tolerance to self-antigen potentially associated with defect in genes that regulate immunological self-tolerance and genetic variation that alter immune regulation. So back to the age, we'll focus now on prepubertal disease onset, have no gender prediction, present unique clinical and laboratory features at disease onset, often display a typical presentation and require higher doses of corticosteroid and more immunosuppressive agents, and rarely to put the patient in remission or even low disease activity. So if you see a patient, let us forget lupus, any patient with early onset, atypical presentation, and familial clusters, you need to consider, or it's likely genetic factor play a critical role in the pathogenesis. So these three players, early onset, atypical presentation, and family history of similar condition, means there is genetic factor until proof otherwise. So over the past decade, rare etiologies for lupus have been discovered. Several pathogenic gene variants have been linked to the onset of lupus. So there is lupus manifestation and there is pathogenic gene variant. So this is what we call it monogenic or Mendelian lupus, or if you want to call it inherited lupus. So the vast majority, if not all, cases of monogenic lupus present with early onset disease, and we are talking about less than 5 years of age, and we are seeing patients maybe in the first year of age with lupus, not typical like adult, but they have disfiguring skin rash, they have alopecia, they have lymphadenopathy, hepatosplenomegaly, and they also have some autoimmune phenomena, including antibodies. So what is the definition of monogenic lupus? I already mentioned part of it, but let me put it in more clear way. It's a rare form of lupus caused by high penetrance pathogenic genetic variant leading to early onset disease with a wide range of phenotypes from mild to severe presentation. And you can imagine the manifestation, including recurrent infection. So one of the manifestation, because they have some genetic variant which may overlap with immune deficiency diseases, present with recurrent infection, and some of them they have basal ganglia calcification. Of course, they have arthritis and lung disease, infiltration. All these can be a manifestation. And there are, this table shows the main pathways and genes involved in pathogenesis of monogenic lupus. Although these, you can see C1q, which is the famous gene mutation causing lupus, but DNase 1L3, this is the first time described or reported from our clinic, because we are seeing a lot of cases. And name it, there are many gene mutations. So although these pathways and genes differ, their networks intersect, ultimately creating a vicious cycle. So the complement, the apoptosis, and the nucleic and other interferon pathways overlap and ended with this clinical manifestation. And this figure highlights a selected group of genes responsible for monogenic lupus. Some are associated with prominent systemic autoimmunity, such as autoimmune cytopenia, while others presented with significant cutaneous manifestation. Yes, these genes causing monogenic lupus, but some of those patients presented with prominent clinical manifestation more than others. So if we talk about the most common one, which is complement deficiency, namely C1q, we have to remember complement has good and bad role. The good things, which is biological function, to remove of apoptotic cells, clearance of immune complex and cell lysis, while it may also involved in if there is a deficiency causing or predisposed to lupus, and axis complement activation play a role in organ damage. So patients with homozygous complement deficiency develop lupus, and the most common one among complement deficiency is C1q, but C4 deficiency also one of the complement you need to consider it, and also C2. Probably nowadays, because with advanced molecular genetics and the interferon considered one of the important pathways, so majority of single gene mutation that led to monogenic lupus are classified as interferonopathies, and highlighting the connection between the pathogenesis of monogenic lupus and interferon dysregulation. So there is some overlap between these two entities, and you can see the monogenic lupus have higher level of interferon type 1 and correlate with high ANA and SLEDAI or disease activity score. And this figure showed the overlap between the autoimmunity and autoinflammatory diseases, which is mainly the connection between the two entities, the interferon pathway involvement. So this is from our clinic. We are seeing complement protein defects from protein directly involved in interferon pathway, and also from endonuclease gene defect and others. And we published this couple of years. This is not for reading, but just to show you how extensive the manifestations in those patients. And nowadays we are trying to see if there is any correlation between the genotype and phenotype. So the SLE or lupus, you can classify it based on the pathways or the underlying cause. If there is genetic defect, probably in the line of interferonopathy, probably it will be in line of autoinflamm, or if it's not, probably in the favor of autoimmunity. So I will share with you a couple of cases. This is a 13-year-old girl. Notice that her presentation at 2 years. So this is early onset. And she has digital vasculitis, and you can see her photos. She has extensive alopecia, skin rash, scaly, and also she has recurrent otitis media. And she had also nephritis class 3 and ended with CNS involvement. She's paraplegic with lower limb spasticity, and you can see the CT or MRI showed basal ganglia calcification. and there is a strong family history. So everything you want, it's there. And unfortunately, she developed rare complication, which is pancreatic pseudocyst, huge pancreatic pseudocyst. All this one is a cyst in the pancreas. And she also has recurrent chest infection. Unfortunately, she had also bad disease treated, and we believe the C1q is very low, undetected. So we believe this is a case of C1q deficiency. Of course, this is monogenic lupus. If you apply the AOLR or ACR, whatever criteria, she met the classification criteria. The second case is a 9-year-old boy presented at the age of 3 years. Okay, and he presented with intermittent fever, polyarthritis, ankle involving the ankles, knees, and elbows, small joints. No history of skin rash, had hepatosplenomegaly, bilateral papilledema. Now, what's the connection between arthritis and papilledema? It's a bit weird. So this is unusual, although this patient was managed as polyarticular GIA. And he has, the parents are first degree cousin, and there is a history, a family history of lupus in the family. And the workup showed high inflammatory markers, ANA double strand, low complement, and he had arthropathy, as you can see in the photos, and also the MRI showed white matter changes. So definitely this is a case of lupus, and most probably monogenic because of the early onset, less atypical presentation and family history. And we did the gene, and the WES or genetic test, and came back positive at DNase 2 gene, which is known cause for monogenic lupus. The third case, an 8-year-old girl had recurrent infection, bacterial and viral. She had ataxic gait and facial palsy. She had pancytopenia, lymphopenia, high inflammatory markers. She had high ANA double strand, low complement, proteinuria, and everything is there. She had nephritis, interestingly class 4 with ANCA associated vasculitis proved by the biopsy, and brain MRI showed chronic left cerebral infarct, and T lymphocyte marker very depressed. So this is most likely we are dealing with immune deficiency case because of the recurrent infection and the T lymphocyte suppression. However, with the presence of these autoantibodies, we need to consider lupus, especially already we proved that she has nephritis. So if you apply the classification criteria, she fulfilled the classification criteria. But for sure, this is not the usual case. So this patient deserved to go for genetic testing, and this is what we did. And it came positive for homozygous variant of PNP, which is well known as SCID, or severe combined immune deficiency. So this patient has immune deficiency and lupus manifestation. Can we call it monogenic lupus? Yes, we can. But definitely the treatment will be different from the usual lupus. So the key here, all those patients presented with early onset, positive family history, atypical presentation. If you have the facility to do genetic testing, you will find the answer most likely. And this is from the literature, not my patient. 2-year-old girl presented with fever, respiratory distress, erythematous rash, polyarthritis, again, young age. At the age of 3.5, presented with fever, walking disability, symmetrical polyarthralgia, oral aphthous ulcer, and she had exaggerated deep tender reflexes, clonus, and spastic paresis, and she had pancytopenia, low complement, ANA double strand, and again, if you apply the classification criteria, she met the classification or the criteria for lupus. And the genetic testing came positive for ACP5, which is again known gene causing lupus. So those patients, the key or entry point is the age atypical presentation, and of course with autoimmune phenomena in form of autoantibodies. So now the question, what is the relationship between monogenic lupus and SLE? Is it a subset of SLE? Is monogenic lupus a subset of SLE, yes or no? From the question, no. At least this is my personal perspective. I don't think it's a subset of SLE. It is a distinct entity, separate entity. Most likely, yes. And I believe both monogenic lupus and SLE, systemic lupus erythematosus, are subset of lupus. So we have lupus, we have monogenic lupus, we have systemic lupus, as we have neonatal lupus, as we have cutaneous lupus, drug-induced lupus. So we need to consider monogenic lupus as a separate entity from systemic lupus. We'll use lupus as the umbrella, and we can consider these separate entities as alone. And what is the similarity between differences between monogenic lupus and childhood SLE? I will not read it, but again, I keep saying the early onset, atypical presentation, and probably high risk of or recurrent infection. Now, we prove that we compare the phenotype disease course differences in monogenic lupus and sporadic childhood lupus. And this is recently we found, we compare our cohort, and we found monogenic lupus often have early onset, strong family history, and guarded prognosis due to disease severity and frequent infection. And most likely due to high consanguinity, because this high consanguinity in our society is very high. So what have we learned so far? Monogenic lupus is a separate entity, potentially differing from sporadic childhood systemic lupus erythematosus. It's highly complex and heterogeneous disease with a spectrum ranging from mild to life-threatening cases due to varying etiopathogenesis. It may overlap with other monogenic interferonopathies and inborn error of immunity. So what's the workup for such patient? Of course, we need to consider it as lupus, so we need to do the workup for sporadic lupus. We need to do molecular genetic if it's available. And if it's not, we thought this tool will help. And this is published recently. We proposed clinical tool to identify high-risk patient for monogenic lupus. So if there is or lack or limited access to molecular genetics testing, probably this tool is helpful. And we test this tool and we found it very helpful. So if the child score more than 3.5, it will be highly likely to have monogenic lupus in your patient. The treatment, therapeutic approach for monogenic lupus are based on case reports and case series. We don't have any trials or comparison. Treatment is tailored to the pathogenic gene pathways and clinical manifestation and disease severity. And unfortunately, those patients have refractory inflammatory manifestation requiring multi-step or switching treatment approach. Mind you, those patients are higher risk for infection, so we don't need to heavily suppress their immune system. So, but we can use biologic in those patients in form of rituximab or pilimumab or others. We can use JAK inhibitors, and so far we tried all these medications, but in our hand we don't try interferon or enferolumab because recently available in our hospital but restricted to adult, hoping we can get it from them soon. So in summary, monogenic lupus represents a distinctive entity and differs from childhood SLE. It is a construct, I believe it's a construct of heterogeneous group with expanded borders. It is highly complex disease with marked heterogeneity between patients due to different etiopathogenesis. It might overlap with other monogenic inflammatory immune dysregulation disorder, and future unbiased criteria using a clinical score to guide in decision making for monogenic lupus is needed. With that, I will stop, and I hope I am not boring you with this talk. Thank you.
Thank you, Professor Sulaiman. You can come and take a seat with me. I think. You can.
Time to change, or because I have few slides for question, but maybe.
No, I think we have about 5 minutes. Shall we just discuss the
Okay.
any question from the audience, and we'll keep your questions for the tomorrow. You can stay with me or answer the questions. So, any questions that you have from Professor Sulaiman? Professor Sulaiman, is there any place for steroids in the monogenic SLE, lupus?
Well, all lupus, monogenic lupus, used to be treated with the steroids. So definitely steroids play major role. So all our patients, and even in the case report in the literature, they are on steroid. But the question, the steroid sparing agent, which is which, depends on the organ involvement and for the underlying pathogenic mechanism.
Any other questions? Okay, thank you, Professor Sulaiman. So we'll wind up that session.
Sorry.
Yeah. Yes, I think we have.
I have one question.
Is Dr. Sumaira?
Yes, I just wanted to ask that, very often we see hyper-intensity signals on MRI where the patient, although they have no evidence lupus cerebritis. So in children, obviously you can also see the same. So what is your comment on that? How seriously should those be taken?
Well, if I get your question correctly, the MRI findings in childhood lupus with cerebritis, of course, if there is findings, it will appear. And we are seeing patients, and it's known to see findings based on the severity of cerebritis. But for sure, it's one of the modality. Unfortunately, most of the time, the neuroradiologist will report it as non-specific. But you will find abnormal findings. But how to interpret it and to put it in the context of the clinical manifestations is difficult. But for sure, if you see a patient, I will do MRI, and if there is abnormal findings, I will consider it as positive finding.
Yes, so but sometimes you may have high-intensity signals with no clinical manifestation. That's it.
Well, I will not. I will be surprised how it was requested without clinical manifestation to start with. For sure, the MRI will be based on the or the investigation based on the clinical manifestation. So I don't know. I have no experience with patients with no clinical manifestation and underwent MRI findings.
Yes. Thank you very much, Dr. Professor Sulaiman, for that interesting session. And so, just to take a break from your postprandial issues, we have a cup of tea downstairs. Quickly run down where you had lunch and come back in 20 minutes. We are starting sharp as 3:30 with another interesting session on juvenile dermatomyositis and other pediatric autoimmune connective diseases. Quickly run down and come back. Thank you.